So I hope everyone can see this. So the last talk is on epithelioid neoplasms. So epithelioid tumours are tumours of a very wide spectrum of tumours composed of round or polygonal cells resembling epithelial cells with variable pleomorphism, variable growth patterns, so nested, cord-like, sheet-like, and the epithelioid morphology is extremely non-specific and can actually be seen at least focally in up to 10% of sarcomas. So it's extremely non-specific. And first, of course, we need to exclude all the non-mesenchymal epithelioid tumours. Common ones, carcinomas, particularly entities such as adrenal cortical carcinoma, also melanoma, of course, and various lymphomas before we diagnose something that's mesenchymal. And then let's also remember that there are rare epithelioid neoplasms, including germ cell tumour, mesothelioma, paraganglioma/pheochromocytoma, various histiocytic tumours, and Sertoli-Leydig tumours. And the issue that we have when we're trying to diagnose an epithelioid mesenchymal tumour accurately is that there is significant morphologic and immunohistochemical overlap, and sometimes molecular genetic overlap, between different epithelioid tumours. So between epithelioid tumours of different lineages even. And this can be very confusing. So we've talked about tumours of uncertain differentiation, and there's this group of undifferentiated sarcomas. And hopefully we'll remember that these have four different morphologies, of which undifferentiated epithelioid is one of the morphologic patterns. And we can focus on this at the start of this talk. So epithelioid undifferentiated neoplasms are in fact the least studied to date, and we can see that these resemble melanoma or carcinoma. They tend to be very aggressive tumours with 5 or 10 year survival of only about 40%. And in essence, we can divide them into three principal genetic categories. So for epithelioid undifferentiated neoplasms, we can divide them into three categories by genetics. So this issue has been this has been described by Dr. Agami and a variety of authors, but three genetic groups. So the first is epithelioid tumours with SWI SNF deficiencies, and we'll talk about those next. The second group are those epithelioid tumours with specific rare gene fusions. So Prof has already talked about sclerosing epithelioid fibrosarcoma, which typically has EWSR1 gene fusion, and he's also talked about the GLY1 amplified or rearranged malignant epithelioid tumours. The third group is an extremely heterogeneous group of the epithelioid variants of diverse other entities. So we were talking in the undifferentiated neoplasms lecture of undifferentiated pleomorphic sarcomas representing the undifferentiated pleomorphic endpoint of a variety of tumours of different lineages, and we can essentially say that epithelioid undifferentiated tumours also probably frequently represent the undifferentiated endpoint of carcinomas, melanomas, etc. So these are a highly heterogeneous group. As we know, the epithelioid morphology is very nondescript. Of the epithelioid undifferentiated neoplasms, most lesions driven by deficiency in the SWI SNF complex express pankeratins, irrespective of the type of tumour, the site at which the tumour occurs, and the gene affected. Also, to compound the situation, epithelioid vascular neoplasms frequently express pankeratins, sometimes diffusely. These tumours, these epithelioid undifferentiated tumours, are frequently defined by key genetic markers, which means that we, unfortunately, it benefits us to have access to molecular genetics laboratory or have molecular markers derived from these genetic alterations, i.e. SMARCB1 and SMARCA4. Final thing is for us to not forget epithelioid variants of other entities. So other sarcomas, we talked about epithelioid variant of pleomorphic liposarcoma. Epithelioid variants can also occur in myxofibrosarcoma and rhabdomyosarcoma, etc. So now let's focus on epithelioid SWI-SNF complex-driven neoplasms. So the SWI-SNF, SWI-SNF, switch slash sucrose non-fermenting complex is a very ubiquitous complex and represents an evolutionarily conserved multi-subunit system of more than 20 chromatin remodelers. So this is a chromatin remodeling complex that is ubiquitous and is needed for normal cellular activity. And this complex is encoded by several different genes that map to several different chromosomes. And it behaves in a highly coordinated ATPase dependent manner to regulate chromatin remodeling and influence a huge number of different normal cellular processes, including transcriptional regulation, gene expression, and cellular differentiation and proliferation. And loss or mutation or loss of function of any member of this complex can give rise to tumorigenesis. For reasons that are not clear to us, tumours with deficiency in in a member of this complex manifest histologically with this undifferentiated epithelioid cellular status. And we don't know why that happens, and this happens irrespective of the specific gene of that complex which is affected and irrespective of the cell of origin. So there are many members of this complex, but the key ones that we need to know about are SMARCB1 and the emerging SMARCA4. So SMARCB1 or INI1 is the one that we all know about. It stands for SWI-SNF matrix associated actin-dependent regulator of chromatin, subfamily B1. Also known as INI1, the antibody is often called BAF47 or HSNF5, and it's on the long arm of chromosome 22. Emergingly, tumours can have SMARCA4 deficiency instead. This is subfamily A member 4, also known as BRG1, and this is on the short arm of chromosome 19. So all these tumours that arise from loss of function of one of these members morphologically manifest as tumours with prominent epithelioid undifferentiated looking morphology. But we can subdivide these morphologies into four principal subgroups. So the first is rhabdoid morphology. The second is histiocyte-like morphology of quite uniform and small epithelioid cells, exemplified by conventional type epithelioid sarcoma. The next is anaplastic large cell type, which are these sheets of quite large, undifferentiated appearing cells with nucleolation, very undifferentiated appearance, and these are exemplified by proximal type epithelioid sarcoma. And the most rare morphologic manifestation is as a round cell neoplasm. So here we have a wealth of tumours which are defined by loss of SMARCB1. Malignant rhabdoid tumour, 100% of these almost show SMARCB1 loss. Epithelioid sarcomas, more than 90% of these show SMARCB1 loss. More than 70% of epithelioid MPNST, more than 40% of epithelioid schwannomas, variable numbers of myoepithelial tumours, most frequently in the pediatric population, and sometimes rare examples of extraskeletal myxoid chondrosarcoma or poorly differentiated chordoma. And the ones that lose this, the rare ones that lose this, manifest with frequent epithelioid morphology. Let's also remember that a variety of carcinomas, frequently large cell carcinomas, can show SMARCB1 loss in various organs, including sinonasal undifferentiated carcinoma, those in the GI tract, pancreas and kidney, and then a variety of tumours that arise intracranially, including atypical teratoid rhabdoid tumour and others. SMARCA4 loss is emergingly characterized in a variety of tumors, mostly epithelial. So ovarian small cell carcinoma, formerly known as small cell carcinoma of hypercalcemic type, is defined by SMARCA4 loss, as well as some endometrioid uterine adenocarcinomas, a proportion of sinonasal carcinomas, and a variety of aggressive large cell malignancies in organ or visceral sites, including non-small cell lung cancer and those of the pancreas, GI tract, and GU tract. And then we'll talk about this later, but there is the new clinicopathologic entity of SMARCA4 deficient thoracic sarcoma. So let's talk about SMARCA4 deficient thoracic sarcoma. This is a new entity in the 2021 WHO Tumours of the Thorax, now known as SMARCA4 deficient undifferentiated thoracic tumour, because authors are not quite aware yet of the exact provenance of this neoplasm. This is a high-grade malignant neoplasm, significantly involving the thorax of adults. And again, we've probably underdiagnosed this in the past because we have probably called this undifferentiated carcinoma. So these tumours typically manifest with undifferentiated or rhabdoid morphology, but they are all unified by the presence of diffuse loss of SMARCA4. And that these represent a very pronounced clinicopathologic entity. They typically occur in middle-aged males. The median age is 48 years. They occur in the adult population, but include occurrence in elderly patients, but usually middle-aged patients, male patients, who are typically smokers. These tumours have shown a genomic smoking signature, and more than 50% of patients have shown smoking-associated bullous emphysematous changes in the surrounding lung. These occur within the thorax, in the mediastinum, pulmonary hilum, pleura, and the lung is at least focally involved in most cases. These have a universally poor outcome, with a mean overall survival of between 4 to 7 months after diagnoses, and typically frequently these patients have metastases at presentation, including to lymph nodes, adrenals, brain, and sometimes these can also metastasize to the abdomen and pelvis. And when there is coexistent abdominal disease, it can be hard to define a primary site of origin. So patients have typically biallelic inactivation at the SMARCA4 locus. There are multiple non-recurrent copy number abnormalities, including a frequent p53 inactivation. However, it is still unclear as to whether these tumours are related to non-small cell lung cancer. So about 45% of these have driver mutations associated with non-small cell lung cancer, such as KRAS, and also smoking mutation signatures. Also, about 5% of these tumours are hybrid cases with conventional non-small cell lung cancer. So some authors have postulated whether these simply represent a de-differentiated endpoint of SMARCA4 deficient non-small cell lung cancer. It doesn't seem to be that simple because these tumours completely lose any evidence of epithelial expression, including immunohistochemically. And also on gene expression profiling studies, they are said to have clustered very separately to non-small cell lung cancer. And so, at least for now, this is regarded as a distinct clinical entity due to significant clinical and phenotypic differences with non-small cell lung cancer. So morphologically, these are composed of variably cohesive, large round epithelioid cells with vesicular chromatin and prominent nucleoli. They look quite undifferentiated and anaplastic, but relatively monotonous. So there is little pleomorphism, although there can be focal mild to moderate atypia. Some of these show rhabdoid morphology. These are high-grade tumours associated with mitotic activity and necrosis. Unequivocal epithelial differentiation is absent, although 5% are juxtaposed to conventional non-small cell lung cancer. So this is a variety of morphologies. We can just see high-grade, large cells. with an epithelioid undifferentiated morphology associated with mitotic activity, present as sheets, cords, nests, or trabeculae, so the architecture can vary, but we can also see that there is no evidence of any epithelial differentiation. No lumen formation, no keratinization, no intercellular bridging, completely undifferentiated tumours. Here we see the diffuse, completely diffuse SMARCA4 loss. We can see the nice control in the surrounding lymphocytes and the endothelial cells. There can, however, be diffuse severe reduction instead of loss, apparently in 25%. A small number show loss of SMARCA2 as well. There can be variable cytokeratin expression, but this is typically very focal or very focal weak, never diffuse and strong. Also variable CD34. Let's remember that conventional carcinomas virtually never show CD34 expression. Also variable SOX2 and SAL4, so they are supportive markers, and variable neuroendocrine marker expression with very rare TTF, P40 and P63, but we're talking rare and focal, not strong and diffuse. We can see CD34 expression on the left, quite strong and multifocal, which is unusual because most carcinomas do not express this marker. And we can see on the right the typical, if keratin is expressed at all, the very typical focal expression, so scanty focal expression, never diffuse or multifocal. Very diffuse loss of SMARCA4. The differential diagnosis is wide and, of course, includes large cell carcinoma with SMARCA4 deficiency, as we mentioned, in 5% of non-small cell lung cancers, neuroendocrine carcinoma, nut carcinoma, another highly aggressive carcinoma. Also metastatic SMARCA4 deficient carcinoma from other sites, such as the GI tract, the pancreas, the kidney, and the gynecologic tract. Also germ cell tumor, melanoma, and lymphomas. Mesenchymal tumours, the particular sarcomas that we need to rule out are the chick-rearranged round cell sarcomas, epithelioid sarcoma, and malignant rhabdoid tumour. So now we move to epithelioid sarcoma. Epithelioid sarcoma is something that a lot of us are familiar with because if we haven't come across them in the clinical setting, we probably have seen examples in box sets and preparing for exams and so on. And this is for us to be aware of the morphologic variants and the caveats. So this is a malignant mesenchymal neoplasm with partial or complete epithelioid morphology and partial epithelial immunophenotype. There are two clinicopathologic subtypes. The classical type, which has this very typical morphology of a pseudogranulomatous growth pattern, typically occurring in acral sites, and the proximal variant, which occurs at more proximal truncal sites and lacks this pseudogranulomatous pattern with a geographic necrosis and is just composed typically of diffuse nests of large epithelioid cells. Classical type outnumbers proximal type by 2-1, and both of these are genetically associated with loss of SMARCB1 activity, manifesting with INI1 or SMARCB1 nuclear protein loss. So the classical type has this very distinct morphology. It arises in adolescents and young adults. Its etiology is unknown, but these are typically superficial tumours that occur as non-healing ulcers in the skin and extending to subcutis. They typically occur in the distal limb, sometimes the trunk, but on the limbs, particularly the distal upper extremity, so the fingers and hand, are where this tumour predominates. These are generally superficial tumours in the dermis and subcutis and are high-grade malignant tumours with local recurrence rate of up to 80% and metastases almost 50%. Let's also remember that epithelioid sarcoma is one of the sarcomas that has a propensity to metastasize to lymph nodes, where we can mistake it for metastatic carcinoma. So classical type epithelioid sarcoma are typically ill-defined lesions composed of sheets and nests of essentially uniform, polygonal to sometimes more spindled cells with minimal pleomorphism. And there is this prominent surrounding look of necrosis, so geographic necrosis with variable fibrinoid material and variable inflammation and fibrosis. So this very busy look and this geographic pattern of necrosis, which is easy to spot in a picture here, but this can have subtle morphologic features, particularly on biopsy, particularly because these cells, constituent cells, are very bland, and we may mistake them as histiocytes. And so, if there is variable myxoid stroma and the neoplastic component is underrepresented, we may miss this as a neoplasm and diagnose it as an inflammatory process. So we can see the geographic necrosis with variable inflammation and fibrosis. And we can see its morphologic mimic granuloma annulari, which actually looks pretty similar. And we can see the cells, the histiocytes of granuloma annulari, and how bland they look, and really how bland epithelioid sarcoma, classical type epithelioid sarcoma lesional cells can look. On the left, we can discern that this is a neoplasm. There is too much, that there are too many of these cells, even though they're uniform, even though they look bland and histiocyte-like and small. But in a tumor on the right, it is really hard to see that there is a neoplastic component. So again, we have to know that this tumor, we have to have this an index of suspicion of this tumor, particularly if we are looking at superficial biopsies on the extremities of young patients. We need to know that epithelioid sarcoma can manifest in a very subtle way, and it always pays to do immunohistochemistry with a pancytokeratin to spot these cells. Again, pretty nondescript and subtle morphology with these classical type cells being bland and quite small and resembling histiocytes. So always, when we're looking at a core biopsy in superficial tissues, particularly the extremities of young and actually any age patients, we should remember that epithelioid sarcoma can look very subtle and do a pancytokeratin. Sometimes there can be rhabdoid morphology, although this is more common in the proximal variant. The cells can spindle, particularly at the periphery of these nodules, and sometimes the tumor can be present as solid sheets. Sometimes there can be a cord-like distribution of cells with variable stromal desmoplasia, and sometimes there can be spindling. Epithelioid sarcoma, both variants are known for their dual immunophenotype of strong expression of epithelial markers, seen in more than 95% of cases, and strong expression of CD34, which is seen in more than half of cases. And again, just to reiterate that these tumors can highly resemble undifferentiated carcinoma. And we need to always have that index of suspicion for epithelioid sarcoma, particularly as carcinomas typically do not show CD34 expression. The keratin is seen in virtually all ES, typically diffusely, sometimes more focally, particularly in the proximal variant. This is a list of the cytokeratins that are positive in epithelioid sarcoma. And just to note that pancytokeratins are positive, low molecular weight keratins, 8 and 18, and CAM5.2 are positive, but 34 beta E12 is positive in only 50%, and CK56 is usually negative or only focal. Here we see the diffuse and strong CD34 expression, which is extremely useful in distinguishing epithelioid sarcoma from carcinoma. Again, epithelioid sarcoma on the right next to undifferentiated carcinoma, and there is no morphologic difference between the two. Epithelioid sarcoma in a lymph node, again, we can mistake this for metastatic carcinoma. So more than 90% of epithelioid sarcomas of either type show loss of INI1, diffuse loss. A minority, so the 10% that show retention of INI1, may show deletions in other members of the SWI-SNF complex, such as SMARCA4 or SMARC-C1 or SMARC-C2. And just for us to note that tumours in the differential diagnosis principal differential diagnosis. So carcinomas, other than a very small subset of large cell carcinomas, carcinomas are typically positive in nuclei for SMARCB1, INI1. Melanomas are invariably positive. Other epithelioid neoplasms, which can express keratin in the differential diagnosis, such as EHE and epithelioid angiosarcoma, are also positive for INI1. There can be variable cyclin D1. I don't know that many people would really use this. There can be variable SMA, particularly in the spindle cell component. And importantly, between 40 and 65% can show ERG expression, i.e. we can mistake epithelioid sarcoma for an epithelioid vascular neoplasm, such as epithelioid angiosarcoma. So 40 to 65% are ERG positive. Morphologic variants, the cells can be disposed within myxoid stroma. Sometimes they can be giant cells, and let's just mention the differential diagnosis of pseudomyogenic hemangioendothelioma, which occurs in a similar clinical context to epithelioid sarcoma and can morphologically and immunophenotypically mimic epithelioid sarcoma. In fact, previously authors were called this fibroma-like variant of epithelioid sarcoma or epithelioid sarcoma-like hemangioendothelioma, and we'll discuss that. So proximal type epithelioid sarcoma briefly lacks the pattern of geographic necrosis and generally manifests as diffuse sheets of large anaplastic type epithelioid cells with nucleolation, with an undifferentiated carcinoma-like pattern. These typically occur in an age group probably 10 to 15 years older than the patients who have classical type epithelioid sarcoma, but can occur in a wide age group from early teens to elderly patients. These occur in a more proximal distribution, so proximal limbs and limb girdles, the midline of the trunk, pelvis, perineum, buttock, vulva, thigh, and shoulder. These can be subcutaneous or deep, but are more often deeply infiltrating soft tissue masses, and they are typically more aggressive even than classical epithelioid sarcoma. So we can see these sheets of anaplastic looking undifferentiated epithelioid cells. Often there is at least a component of rhabdoid cells. We can see that there is a lack of the geographic type necrosis that we see in classical type epithelioid sarcoma. Cytokeratin may be more focal in proximal type epithelioid sarcoma. So the differential diagnosis of both classical type and proximal type includes reactive lesions. So we always have to have epithelioid sarcoma as an index of suspicion and not confuse it for necrotizing granulomatous inflammation, rheumatoid nodule, or granuloma annulare. Non-mesenchymal neoplasms, well, it is distinct from melanoma. That should be fine to make a distinction immunohistochemically. Carcinoma, large cell lymphoma. So carcinoma, clinical picture is really important. If we're seeing a tumor as one focus in one particular site with no visceral sites or any skin sites, then we have to think of epithelioid sarcoma, but we first need to exclude much more common carcinoma. And then we will talk about the differentials, the first of which is malignant rhabdoid tumor. And so we know that the rhabdoid phenotype is highly non-specific and is present in many, many unrelated tumours, including in melanomas, a variety of carcinomas, even in lymphoma, some mesotheliomas, some meningiomas and gliomas, and a variety of sarcomas. But malignant rhabdoid tumour predominantly occurs in the paediatric population in patients who are 3 years old or younger. There are morphologically similar tumours in adults, but they are rare. These can occur in the deep soft tissues or the kidney or brain, where they are called atypical rhabdoid teratoid tumour, and these are highly aggressive neoplasms with a dismal 5-year survival of 15%. So they are infiltrative masses with large eccentric nuclei and abundant cytoplasm, with these rhabdoid inclusions composed of whorls of intermediate filaments. They can be present as sheets or as trabeculae with variable fibrous septa associated with mitosis and necrosis. There is a rare variant in which the cells are predominantly primitive, undifferentiated round cells with only focal rhabdoid morphology. These are invariably keratin positive, with 80% positive for at least one epithelial marker. Also EMA positive. 50% shows variable neural marker positivity. There can be occasional SMA and S100 protein expression, but in contrast to epithelioid sarcoma, these are CD34 negative. In contrast to rhabdomyosarcoma, they are consistently desmin negative. They're negative for melanocytic markers and GFAP. So actually diagnosis in the particular clinical context is relatively straightforward. INI1 loss is seen in almost 100% of cases. So some words on epithelioid endothelial tumours. So the principal ones are as follows: epithelioid hemangioendothelioma, epithelioid hemangioma, epithelioid angiosarcoma, and as we mentioned, pseudomyogenic hemangioendothelioma. So we'll only discuss briefly the ones that come into the differential diagnosis of epithelioid sarcoma. And the problem with the epithelioid endothelial tumours is that frequently they show strong keratin expression and they can resemble carcinomas, particularly with solid morphology. There is much overlapping morphology between these tumours and also overlapping immunophenotype of keratin and vascular markers, but there is differing clinical behaviour. So we need to make sure we are accurately diagnosing them, and there is also differing genetics and hence potential for targeted therapies. So pseudomyogenic hemangioendothelioma is quite a confusing entity that has been written about for a long time by various authors, including the team of Dr. Billings, Dr. Mirror, and Drs. Hornick and Fletcher, as well as other authors. It's so-called pseudomyogenic hemangioendothelioma because it is a full vascular neoplasm. So it is a vascular neoplasm that does not show vasoformation, similar to EHE. So it's a hemangioendothelioma, and it has these ovoid to more spindled, very large cells resembling myoid cells, which is where it gets its name. But there's always been a lot of confusion with this tumour because of its similar clinical picture to epithelioid sarcoma, similar age group, and somewhat similar morphology and immunophenotype, which is why previously these have been called fibroma-like variant of epithelioid sarcoma or epithelioid sarcoma-like hemangioendothelioma. Let's remember that this is principally more a spindle cell rather than, frankly, epithelioid neoplasm. But the morphology is variable and we need to get to grips with it so that we don't overcall it as epithelioid sarcoma because of its similar clinical picture, and incredibly importantly because it is much more indolent in its behavior than epithelioid sarcoma. So this is a rarely metastasizing endothelial neoplasm. It's an endothelial neoplasm that does not show vasoformation, and its behavior is intermediate. It typically occurs in young adult males, so a similar age group to the patients who get epithelioid sarcoma, and manifests typically as multiple discontinuous nodules, frequently in different tissue planes. So 60% of cases, patients have nodules in different tissue planes of one site, and it histologically mimics epithelioid sarcoma or a myoid tumour. So we can see on this imaging of the discrete nodules in various tissue planes of the same anatomic location. And it's important that we don't overcall this as epithelioid sarcoma because it is only rarely metastasizing. In contrast to epithelioid sarcoma, there is an extremely low rate of nodal or distant metastases, less than 5%. However, local recurrence is relatively frequent in about 60%, often multiple. So these tumours occur in young to middle-aged adults, but the mean age is relatively young males, 30 years, and only 20% occur in patients who are older than the age of 40. So these can occur at a variety of sites, particularly extremities. 55% occur in the lower limbs. So this is in contrast to epithelioid sarcoma, where the majority occur in the upper limbs. They can also occur in the trunk and more rarely the head and neck. And we can see the percentages manifesting at different sites. So 75% of them show manifestation in cutaneous, subcutaneous sites, intramuscularly 50%, and 20% actually show lytic bone lesions. Just remember that this tumour has a dominant spindle cell morphology rather than an actual epithelioid morphology. These are composed of plump but generally relatively bland, although plump, spindle cells and sometimes ovoid cells with this somewhat fibrohistiocytic morphology. Only a minority of cells are actually epithelioid. It's a full vascular neoplasm, but vasformation is not seen, and vacuoles representing rudimentary or early lumen formation or vascular formation are extremely rare. Mitotic figures are rare. About 50% of these show variable neutrophilic infiltration, which is helpful. Let's see the morphologic spectrum here. So on the left, we see these sheets to fascicles of very plump, quite alarming looking spindle and sometimes ovoid to more epithelioid cells with a somewhat fibrohistiocytic morphology with vesicular nuclei, prominent nucleoli. And in a sheet-like distribution here with an inflammatory cell infiltrate, frequently containing scattered neutrophils, sometimes just very, very spindled. And here we can see, again, the plumpiness, a somewhat fibrohistiocytic looking morphology of the cells, and a cell that is attempting to form an intracytoplasmic vacuole, i.e. rudimentary vasformation. So the immunophenotype is really important and something that we need to get to grips with. So these are keratin positive, but interestingly, these show diffuse and strong A13 expression, but negative MNF116, which is which is extremely strange. I personally find A13 to be the most sensitive pancytokeratin, and I recommend it in this. So 100% are positive for A13, MNF completely negative. So A13 is superior in this context and many contexts. This is a full-on vascular neoplasm. So most of these show strong expression of CD31, FLY1, and ERG. So it's strong expression of the vascular markers. Of course, this is in contrast to epithelioid sarcoma, although 40 to 60% of epithelioid sarcomas show ERG expression. In contrast to epithelioid sarcoma, CD34 is negative, and also in contrast to epithelioid sarcoma, INI1 is retained. Yeah, so we've got keratin expression, strong A13, absence of MNF116, expression of vascular markers CD31, FLY1, ERG because it is a vascular neoplasm, negative CD34 and retained INI1. And just a quick note on vascular neoplasms, the most sensitive markers, in my opinion, are ERG and CD31. CD31, if you don't have ERG, is the most sensitive for angiosarcoma. CD34 only stains between about 50 or 60% of them. So 31 is really good, but we just need to remember not to overcall CD31. So the expression of CD31 in a vascular endothelial neoplasm should be really strong and diffuse. And we can see that here. We should not overcall a histiocytic inflammatory population scattered within the cells that show more moderate rather than strong, less specific, often granular cytoplasmic expression as true expression. So CD31 should be in vascular markers diffuse and strong like this, and we should not overcall CD31 showing weaker staining to moderate staining in a histiocytic population. INI1 is retained, as we mentioned. And genetically, pseudomyogenic hemangioendothelioma is associated with a variety of fusions in which FOSB pairs with a variety of partners, including SERPINE1 and WWTR1. FOSB immuno is useful in this particular context. Diffuse and strong nuclear expression is seen in nearly 100% and is not seen in its morphologic mimics. Again, if you have this marker, I've never used this. So next, very briefly, epithelioid angiosarcoma. I think most of us are relatively happy with it. It occurs in various contexts. in cutaneous lesions in the elderly, in chronic lymphedema, as a primary intraparenchymal lesion of the breast, or more superficial post-radiation tumor of the breast, and as primary neoplasms in viscera and soft tissue, typically affecting older adults. And generally, most of us are quite happy diagnosing angiosarcoma, but sometimes these can be very, very solid with almost no discernible vasformation. So again, we need to have an index of suspicion for this, and just remember to look for subtle vasformation. Again, solid sheets, there is some hemorrhage, but nothing that we can see in this particular focus of definite vasformation. So these cells typically have this very undifferentiated look with prominent nucleoli and vesicular nuclei. And we need to look for areas of more typical angiosarcoma. Sometimes there can be rhabdoid change and papillary or pseudoglandular structures with a variable inflammatory infiltrate. And again, CD31, best markers are ERG and diffuse and strong CD31. But these tumours can also variably show AE13 expression, sometimes very strongly and diffusely, and mimic carcinoma. So we need to remember that caveat. And for a very solid tumour that we're going to call undifferentiated carcinoma, just remember that it could be just very solid looking epithelioid angiosarcoma. So again, keratin expression and a variety of markers associated with vasformation. INI1 is always retained. Just to sail through epithelioid hemangioendothelioma, because again, this has a very characteristic morphology that most of us are aware of, and when it has characteristic morphology, it can be relatively straightforward to diagnose. EHE is a malignant vascular neoplasm of epithelioid endothelial cells with this very prominent myxohyline matrix, mostly characterized by WWTR Campter fusion, most frequently occurs in middle-aged adults and can occur at any site, skin, subcutaneous, or deeply in viscera, particularly in the lung, liver, and bone, where there can be multifocal rather than metastatic disease. Up to 50% arise from or around a large vessel, and the typical pattern is of infiltrative cords, strands, and nests of these relatively uniform, mildly atypical epithelioid cells in this very characteristic myxohyline stroma. So this stroma is a hallmark of epithelioid hemangioendothelioma. Again, the very characteristic stroma. Sometimes this tumor is a little bit more myxoid, but the stroma, glassy hyaline looking stroma, is the hallmark. So these are composed of epithelioid to sometimes spindle cells, relatively minimal atypia. Mitotic figures are not prominent. Again, this, like pseudomyogenic hemangioendothelioma, is another vascular neoplasm that does not show vasformation. But sometimes there can be variable cytoplasmic vacuolation with intracytoplasmic lumina and a single erythrocyte, or a couple of erythrocytes in the lumina. These have a variable clinical course. These are fully malignant, but the biologic behavior can be difficult to predict. And some authors say that marked atypia, spindling necrosis, and a mitotic index of more than 2/10 hyperhar fields is associated with a poorer outcome. So again, these are vascular neoplasms, so we would expect them to show expression of vascular markers, CD34, 31 and ERG, but 25% show variable keratin expression. We can see how nice and strong the nuclear ERG is, and the CD31. INI1 is again retained. Campter immunohistochemistry can be useful. It's seen in 90% of EHE, and it's not found in other epithelioid tumours. So again, if you have that, that is a useful marker. And genetically, 90% of EHE is associated with WWTR1, Campter1. Sorry, that's 90% of EHE with classic morphology of the strands of relatively uniform epithelioid cells in myxohyline stroma. However, there is an alternate fusion in which YAP1 pairs with TFE3, and it is thought that epithelioid hemangioendothelioma with this fusion might represent a distinct clinical and pathologic subgroup. So we see an example here of YAP1 TFE3 gene-fused epithelioid hemangioendothelioma. And these have variable morphology, but two things to note are that these have been associated with a more solid growth pattern with these nests of cells with brightly eosinophilic cytoplasm. And also these tumours with YAP1 TFE3 fusion are also associated with much more prominent vasformation. So we never see vasformation in typical, i.e. CAMPTOR1 WWTR1 epithelioid hemangioendothelioma, but the YAP1 TFE3 frequently shows these solid nests or much more pronounced vasformation. And the case I have seen was actually incredibly vasformative, unlike any standard EHE, and almost looked like a hemangioma variant. So this is likely going to represent a distinct genetic entity. And so almost there, just quickly to talk about epithelioid nerve sheath tumours. Epithelioid schwannoma. Schwannoma is a nerve sheath neoplasm of differentiated Schwann cells. Most epithelioid schwannomas are sporadic, but some are associated with schwannomatosis. These are typically superficial tumours in the skin and subcutis, occurring over a wide age range, but mostly in middle-aged adults, typically in the extremities, but occurring in a variety of sites. So these are benign, although they can recur when incompletely excised, although very rarely they can show malignant transformation to epithelioid MPNST. Let's remember how schwannomas typically do not undergo malignant transformation, but epithelioid schwannomas can rarely undergo malignant transformation to epithelioid MPNST. So similar to conventional schwannomas, these tend to be circumscribed and encapsulated. They are frequently multinodular and are composed of sheets, nests, and cords of quite uniform cells with vesicular nuclei, small nucleoli, and sometimes pseudo-inclusions that we see in nerve sheath neoplasms with eosinophilic cytoplasm. The cytology is quite bland. There may be mild atypia. Mitotic figures are scanty. And a clue to the diagnosis is that there is frequently more typical spindled cell areas of more conventional schwannoma with antony A and B areas, and the hyalinized thick-walled vessels that we see in conventional schwannoma. This is a picture that Prof has already shown, but another clue to the diagnosis is the presence of EMA-positive perineural cells subcapsularly. So these tumours are typically diffusely and strongly positive for S100 protein and SOX10, also for GFAP. INI1 loss is seen in about 40%. In about 40%, keratin is negative, as are melanocytic markers. Moving on to epithelioid MPNST, again, a little bit hard to recognize because it's rare. This accounts for about 5% of MPNST and is molecularly distinct from conventional MPNST. It is not associated with NF1 patients. It can be associated in up to 50% with a large nerve and can rarely arise in schwannoma. So this is conventional type MPNST, which is usually a spindle cell neoplasm with this pronounced marbling with more hypercellular and hypocellular areas and only focal S100 protein. Epithelioid MPNST occurs in young to middle-aged adults, typically in superficial sites. So deep occurrence is rare, particularly in the extremities. Prognosis depends on size and depth. It's generally less aggressive in its behavior than conventional MPNST. And these tend to be quite circumscribed, multinodular or lobulated tumours with epithelioid cells in sheets, nests, cords, and strands. But frequently, a clue is that there is variable fibrous, hyalinized, or myxoid stroma. So this morphology is quite is not typical of a lot of malignant epithelioid neoplasms. Many of the cells are relatively uniform, although there is variable atypia. They have rounded nuclei, vesicular chromatin, and frequently prominent nucleoli with variable numbers of mitoses, sometimes necrosis, and sometimes, including at the periphery, you may see areas of more conventional-looking spindle cell MPNST. There's variable atypia and pleomorphism. Again, variable atypia. And cells with atypia, including multinucleate forms, in this prominent fibrous stroma. And in contrast to conventional MPNST, epithelioid MPNST shows diffuse and strong S100 protein and SOX10. Iron I1 loss is seen in approximately 75%. Melanocytic markers are negative, and H3K27ME3 is retained, in contrast again to conventional MPNST. We can see the very apparent iron I1 loss, and we can also see the SOX10 expression. So in contrast to conventional MPNST, diffuse and strong SOX10 and S100 protein expression and iron I1 loss. There may be focal epithelial marker expression, but it's negative for melanocytic, myeloid, and vascular markers. And before we end, just 1 minute on epithelioid variants of other sarcomas, because we tend to forget these. So just to highlight sclerosing epithelioid fibrosarcoma, which Prof mentioned, epithelioid inflammatory myofibroblastic sarcoma, so an aggressive IMT variant, epithelioid GIST, which sometimes we have difficulty with because it can variably resemble renal cell carcinoma or adrenocortical carcinoma or PEComa, and the epithelioid variant of pleomorphic liposarcoma. And epithelioid variants can also occur in other sarcomas, including myxofibrosarcoma and rhabdomyosarcoma. Pleomorphic rhabdomyosarcoma has an epithelioid variant here. And that ends this talk. Thank you very much, everyone. Thank you.